Last but not least, I'm very happy that I've been joined now by Pierre-Emmanuel. He has had a long day as he opened the studio in the morning, together with Thomas, Marina Berenguer, and Shiv Sarin. Pierre-Emmanuel is also an expert on rare diseases and particularly on vascular diseases. And today we had a symposium on vascular diseases. And please, Pierre-Emmanuel, you certainly have to report something.
Absolutely. You know, Ulrich, we had a fantastic session this afternoon on PSVD, Porto-Sinusoïdale vascular disease. You know, this entity is a new name.
Yeah, but I didn't know it. You
know. But I don't think this is this is not a new entity. I'm sure you met already those patients. I'm sure you met those patients with portal hypertension, and you do a biopsy, and the pathologist replies there is no cirrhosis.
Yeah.
And therefore, how do you call that? Say it's intrahepatic because portal vein is patent and hepatic veins are patent. Non-cirrhotic because the pathologist said there is no cirrhosis, and portal hypertension because there is portal hypertension. But intrahepatic, non-cirrhotic portal hypertension is not satisfactory as a name. You can also do, of course, the check for causes of cirrhosis, and there is no Hep B, no Hep C, no alcohol, and you say this idiopathic, idiopathic portal hypertension, which is not satisfactory either. So, and also there is a problem with this term. You know, it implies that the disease starts with portal hypertension. Do you know any chronic liver disease that starts with portal hypertension?
No.
Of course not. So it means that we completely overlook the beginning of the disease with this term. So what can we do? We can ask the pathologist what he or she sees. And they see NRH, you know, nodular regenerative hyperplasia, or OPV, obliterative portal venopathy, but these entities can overlap the one with the other, and therefore it's not a good solution too. And therefore the Valdi group and ISL consortium proposed a name some years ago, which is PSVD, standing for Porto-Sinusoïdale vascular liver disease. Why this term? Because at histology, this is an involvement of the portal veins and the sinusoid, therefore Porto-Sinusoïdale. This is a vascular liver disease, therefore vascular. And this is a disease because patients have complications. They can develop ascites rarely, but they can often develop gastrointestinal and also portal vein thrombosis. Therefore, the term chosen is PSVD, Porto-Sinusoïdale vascular disease, and we discussed that this afternoon in a very interactive session. And as often in medicine, as soon as you solve an issue, you create new question, open new question, and this is what is happening. And we discussed that this afternoon, and we had many questions from the audience. A problem or a point is that this is a broad entity, which is good. It starts from patients without portal hypertension to patients with portal hypertension, and various risk factors too. But what we would like is to identify subgroup of patients with differential outcome. And this is the topic for current research, and Virginia Hernandez this afternoon pointing really to the need of collaborative studies in this rare disease. So I think this is a big take-home message from this, a new name encompassing the whole spectrum of the disease, but a need for refining this entity.
May I ask, can you give a hint pathophysiologically? Is it an endothelial cell disease?
So the short answer would be no, I can't. Mm-hmm. But if I want to elaborate a little bit, we of course have some hypotheses. Basically, there are two main hypotheses. The first one is related to the risk factor associated, which is a risk factor for thrombosis. These patients, 30% grossly, have risk factors for thrombosis like myeloproliferative neoplasm. Yeah. Others have immunological disorders. This is a second, I would say 1/3 of the patients, like immune deficiency. And others also have exposure to drugs. So here you've got the risk factors and likely associated the pathophysiology. But you know, Ulrich, today, while you were at the research think tank on immune-mediated liver disease and cholestatic liver disease, I was attending the Valdig research think tank, and there was also a very interesting discussion on nodules in patients with vascular liver disease.
Which we are all very often sitting in front of these images with the nodules and can't really interpret them. Yeah.
Exactly. This is really a challenge. And to summarize these very fascinating discussions we had this morning, I can say that among patients with vascular liver disease, you can split those patients into two groups. Patients with problem of inflow, and here you find portal cavanoma and PSVD, Porto-Sinusoïdale vascular disease. And these patients develop almost never HCC, almost never hepatocellular carcinoma. Yeah. And these are mostly benign nodules. On the contrary, patients with hepatic outflow obstruction, meaning Beuers syndrome and Fontan surgery, these ones develop hepatocellular carcinoma. And Maxime Renaud, a radiologist from France, shared with us his experience recently published in JHEP, where he demonstrated that the usual pattern of hyper enhancement at the arterial phase associated with washout is absolutely non-specific in this setting. But what is interesting is if you add one sign, that could be hypointensity on T1 or capsula, then the specificity becomes really excellent, particularly if you add alpha-fetoprotein that in this specific setting has a value. So we came with very concrete take-home messages as well as a lot of food for thought with regard to pathophysiology as well in this setting. So today was really an excellent day for me.
Yes. I see it already. It's very good. And these patients are usually not cirrhotic patients, huh?
Exactly. But you point something really important. Among the risk factors for HCC in patients with Beuers syndrome, you find a very long history of Beuers syndrome and thrombosis of the inferior vena cava, suggesting that this long-standing obstruction of venous outflow leads to fibrosis and therefore can favor HCC. So this is a possible mechanism.
And we see that in clinical practice, that these patients slowly develop fibrosis, cirrhosis.
But biopsy should be really, in this setting, easily performed because this is really challenging on the imaging point of view.
Therapeutic aspects, 1 minute?
We did not have so much time to address this, and particularly because there are not so many studies in that. So it's mainly located to the field of Beuers syndrome and hepatocellular carcinoma, where the usual therapeutic are possible, typically TACE, which is an option in this setting, but of course challenging because you've got this hepatic outflow obstruction, therefore the tolerance can be not so good, but this is a possible option together with transplantation, of course.
Anticoagulation? Does it
Anticoagulation in patients with Beuers syndrome is mandatory.
That's mandatory, But in your newly defined
in PSVD, this
PSVD,
in PSVD in Porto-Sinusoïdale.
I can't remember this.
This is an excellent question, and there are ongoing trials on this, testing anticoagulation versus no anticoagulation in patients with PSVD, because for the moment we don't know.
Because you have the risk factors which would overlap with those who develop thrombosis.
Exactly.
Is it also bone marrow disease? So JAK2 and so forth?
It is JAK2 mutation is among the risk factor for PSVD.
Okay, I think we have to come to an end. Pierre-Emmanuel, thank you very much.
Thank you.
You see, vascular diseases also for the future. When you are 25 now and have to think about which direction you should go among others to vascular diseases. Lot to do for the future. I think we have to stop. Thank you for joining us so late. Real pleasure we work together the whole year, so in the governing board. And with that, I would like to thank all panelists of this session. Marco in Chile, thank you for joining us at these strange times. I'd like to thank all faculty and, of course, delegates for your active participation in today's program.